Okay.
Okay.
I have a question for Mr. Anderson.
Yes,
with the
and
chair's
then I'm going
indulgence.
to have Mr. Bonta ask a question. We do have a panelist that has to leave,
Okay.
so
Okay.
You got more than your 3 to 4 minutes, didn't you?
Yes, I did.
So both of you, but I'd like Mr. Anderson to answer the question if that's possible. Both of you talked about employment, supportive employment. You know, last year we passed a piece of legislation. I believe it was Mr. Chesbrough's legislation on employment first. I was very disturbed when I got an email from my Bakersfield ARC, who's very involved in, and this is the email with the chair's indulgence. Can I read the email? Is that okay?
Let's keep it brief, but
Okay.
we will do that.
Another contract on February 4th, 2014 with BARC received a 30-day cancellation letter for the grounds maintenance service at the CHP office in Fort Tejone's offices, stating that a civic service employee has been assigned to the duties. Under this email, the Bakersfield ARC had provided jobs through contracts with the CHP office for janitorial, for grounds maintenance, for all of these things. And some of the statements that were made in this email were that they did such a good job, the contract was only for 2 to 4 months, and they extended it to 6 months. They never had a day that someone didn't show up and do their job. And then they recently just had to terminate that contract with the Bakersfield ARC because the state employees were upset that these jobs were being contracted out. How are we as legislators going to pass legislation to make employment first and then not allow people to have these gainfully employable positions that they do very well? And as a matter of fact, they found a clause. They were looking for a clause in the contract, and they found a clause that under DGS that they have to contract with 3 civil service employees, and if they don't work out within the probationary period, they can terminate the contract and re-engage ARC. So they're on their second one that hasn't worked out. They have to work through the third one before he doesn't work out so that they can re-engage ARC. Are you willing to work together with the ARC and the legislature to try to make sure that employment first opportunities, or when we require employment first, to make sure that that when they can be gainfully employed, they should be priority gainfully employed instead of by a state worker? I'm sorry, they should.
If you have an answer, please do. If not, this is certainly an issue that I would like to also take to the Labor Committee, which I'm a member of. But if you have an answer, please do. Honor the Assembly member with your response.
Well, my answer is I've met those workers and at a picnic last summer.
It's sad they lost their job.
That they love that job more than anybody loves any job. So my answer to your question is there is no way that that's employment first if we're taking the jobs away from them. It's so important to them.
Thank you.
And I'm going to join my colleague to my left. That is a part of an individual plan, and the importance we have of the details of what actually took place there. I will find out, and I will personally talk with you about what the aspects of that really entails, because I don't have the details relative to that. Our interest is to keep people employed. So if there's a barrier that we need to get through, we'll commit ourselves to it.
Yeah, I appreciate that. The gist of it is that these people had a contract for almost 6 months for gainful employment. They loved their job. They showed up every single day, and somehow
let us
the SEIU found out about it, and now they're gone.
Let us move on. Thank you for the point.
Thank you.
Thank you for the response. We're going to move on to health. Our interest is in hearing where, again, are the opportunities and challenges, gaps, certainly in light of being post-Affordable Care Act. If you could just give us sort of the landscape view, if you will, an overview of a few minutes, and then what we hope is to have the robust conversation into questions and the answers. With that, I'd like to invite Dr. Flores, if you would, please.
Thank you, Mr. Chair and members of the committee, for this opportunity to address you today about health. I'm Dr. George Flores, Program Manager for Prevention in the California Endowment, the state's largest private health philanthropy. I'm a physician with years of experience in family medicine and public health. Regarding gaps and opportunities, my perspective is one based not only on our experience with this foundation, our lessons in working with communities across the state, but is also reflective of collaboration with respected institutions such as the Institute of Medicine, the California Department of Public Health, Prevention Institute, and Trust for America's Health. So with regard to health, our greatest gap is the chasm between healthcare spending and outcomes. We rank first in the world in spending, but 28th in health status. Health status is worst in places that endure adverse social, economic, educational disadvantage, which we know are the social determinants of health. The greatest opportunity, then, is to invest in prevention, and here's why. Non-communicable, preventable chronic conditions consume an extraordinary and growing amount of health spending. Nationally, it's 45% of a $2.6 trillion budget. Here in California, 45% of all of the spending that we do in this state in health goes for these preventable chronic conditions. The chronic conditions that are associated with modifiable risk factors like smoking, nutrition, weight, have an annual expenditure, represent 6 of the 10 costliest medical conditions, and a combined annual expenditure here in California of around $33 billion a year. Indirect costs associated with these preventable chronic diseases related to diminished labor supply and worker productivity and resulting drag on the economic output is estimated nationally at over $1 trillion a year. This is beyond health spending, a huge economic and budget impact on all aspects of what we spend in the public sector as well as the private. This represents nearly 30% of the increase in medical care spending. To become healthier and reduce the growth of spending on medical care, we must change how we approach health and the actions that we take. We need to expand our focus to address how to stay healthy in the first place. How do we afford this? Well, it's called the health care dividend. Preventing disease before they happen, like what we did by eliminating smoking in so many places and decreasing the rate of smoking here in California, have seen a tremendous decline in cancers and heart attacks, strokes, different diseases that relate to smoking. So it saves not only lives, but avoids the huge medical and social costs that happen otherwise. Shifting resources otherwise spent on repairing health to instead addressing the disadvantages and the social determinants of health and preserving wellness and productivity across all communities is the true answer. To leverage the state budget to improve the health of all Californians, we have to do ABC, accelerate investment in developing physical and emotional well-being throughout the lifespan, beginning with our youngest citizens. Broaden our understanding to address health outside of the medical system. And C, create communities that foster health-promoting conditions and behaviors. Some examples of these are making investment in children the highest priority by shifting spending priorities to ensure that families and communities build a strong foundation in the earliest years of life. Fundamentally change how we revitalize neighborhoods by integrating health into community development. Take a broader, more health-focused approach to policy decision-making by our mindset, mission, and incentives across all sectors, gaining the participation of the private sector, too, beyond treating illness to helping people lead healthy, safe, and productive lives where they live, learn, work, and play. Leaders from the state and local health departments in housing, transportation, health, education sectors, public and private financial institutions all must understand the importance of collaboration because we're all in it together, should not all be on the shoulders of government. Establish enduring resources for prevention, such as wellness funds that could be covered locally for distribution to the highest priorities in those places that the people who are there know best will work. Establish the capacity to inform state policy decision-making routinely about impact on health and well-being, including opportunities for prevention. And leverage federal investments in prevention, where we are spending no money, basically at all, to scale up innovative models that improve social and environmental conditions for health, to prevent diabetes, heart disease, stroke, cancers in the first place. Thank you.
Thank you. And now Director Kent.
Thank you. Good afternoon, Mr. Chair and members. So with your indulgence, I might take something from Santee in terms of telling you a little bit about myself. I'm on week 2 as the director, so everything's new and shiny still at the department. I'm a 4th-generation Californian, and I have roots going back to a great aunt that graduated from University of California from medical school, and she spent 20 years at the Department of Public Health, actually in the Child Bureau, or the Bureau of Child Hygiene. So it is with great honor that I took this job, and it's such a fantastic opportunity on the heels of the Affordable Care Act, which was such a dynamic change in the way that healthcare is delivered in the nation, but most broadly in Medi-Cal today. And so with that, we're looking at 2015 as kind of the it's the deep breath after we have, rushed to get to the finish line of 2014 and all the changes that came with that, to now that we have implemented the basic provisions, how do we go about refining our work, addressing, as you would say, the challenges and the opportunities and the gaps, because I think we are a state that has leaned into the Affordable Care Act, and while other states have tried to decide whether they were in or they were out, or whether they were wanting to, take a piece of the Affordable Care Act, I think we went into it with our whole heart. And so, you sit, before us today, and we have a program that serves 12 million Californians and spends $98 billion in this current budget, which is phenomenal. We cover half the births, and so to your interest in having children start out at their very earliest opportunity, being born in a setting in which it's safe, in which the mother received prenatal care, and for which they will go on to be healthy individuals, that are receiving all the preventive checkups. I think that's a system that we are endeavoring to provide to every single one of the individuals that's enrolled with us. That being said, I think that some of the issues that we have in front of us looming large this year for opportunities is the renewal of our state's 1115 Medicaid waiver. Waivers, as I like to explain in very simple terms, it's a story that we, the state, tell the federal government. We go to the federal government and say, there's all these rules that govern how a Medicaid program operates, and if you will let us flex those rules or bend those rules, we'd like to do something different, and here's what we'd like to do. And so our waiver is up for renewal this year, and the previous waiver was called the Bridge to Reform, and that was absolutely critical funding of about $10 billion that we poured into the system to make us ready to implement the Affordable Care Act. And with this renewal of the waiver, we're really looking at it as a place to take it to the new frontier, if you will, to say there are individuals today that are siloed in systems, and it's not enough that you just have coverage and that you're walking around with a Medi-Cal card, but what does that card actually get you? Does it get you, your physical medical services? Does it get you your mental health services? Does it address if you have a substance abuse problem? And so what we're really trying to do is say individuals that utilize multiple systems should not be treated in a silo because their issues are not siloed. And so the waiver is testing out new concepts and trying to get new funding and investment for how we break those barriers down. And so the waiver is a really phenomenal opportunity for us as a state to demonstrate new and exciting ways, both from a payment perspective for how we pay our providers, but also the services that we provide to the beneficiaries in the right setting and at the opportunity in which they are most comfortable being served. The second issue, I think, that is certainly incumbent on the department to address would be a gap if it's not solved appropriately, would be the managed care tax that we have in the governor's budget. This tax was done several years ago in which managed care plans in California agreed to pay a tax that those proceeds were then used to draw down additional federal dollars, and those dollars have supported the Medi-Cal program, and it has grown. Obviously, as Medi-Cal has grown, revenues have grown, and so it's upwards of approximately $1 billion. We have a proposal in the governor's budget to conform with some federal requirements that require the tax to be more broad-based than what it has been. And so we are vitally interested in making sure that we work with the plans and others to make sure that that is secured, because that would be a big gap if it's not appropriately addressed. One of the other issues that I think is important for the department, again, as we are a managed care state, right? There are 58 counties that are now served by Medi-Cal managed care, and the question that you and other stakeholders ask are people getting access to care at the right time, at the right place, and are there enough providers to serve them? So one of the things that we will be working, obviously, closely with you and others on is how do we monitor our plans, our key partners in delivering this care to make sure that people are getting the right access and that we're meeting all the timely access requirements that have been enacted by this state, which are also much more advanced than in other states. We have a lot of Medi-Cal quality monitoring measures that we have implemented, which I have worked with other plans in other states in previous jobs, and I have to say that I think that what we're doing today in Medi-Cal managed care in terms of our quality monitoring is probably going to be something that will be a national leader, because no other state is really doing quite what we're doing in terms of the quality monitoring. So that's certainly an opportunity for greater value and making sure that the purchases that we make are doing the right and the best that we can. Lastly, I think the thing that I would like to say for work that we will be doing, there's really two partners that I consider us to have as a department in terms of how we deliver services. There's lots of people that we work with, but on the front end are our county partners that handle the 12 million individuals that come into the system looking for care. And so we have a lot of systems and automation issues that we have to work with. It's amazing to think that 3+ years ago, when we started the Affordable Care Act, we had to create an IT system to handle all of this, and we did it. It's not perfect by any stretch of the imagination. There are refinements that we have got to do, both to make the state operations between Medi-Cal and Covered California work better, but we also have 58 counties that are doing Medicaid eligibility and enrollment work, and so we have to continue to refine our CalHERE system to make that better. That's a basic business process that we have to work out. And then on the back end, the plans are the other critical factor. So just as the counties provide us with those individuals and find them eligible, we then put them into our managed care plans and say, you know, you have to improve their quality of health. You have to give them, you know, all of the services that we have decided are a priority in providing. And so that's where the good business practices and the partnership comes in, working with the plans more closely. So with that, I will welcome your questions. Thank you.
Thank you, Dr. Flores, and thank you, Director Kern, all of 2 weeks. As a new member, I know exactly how you feel. We just scheduled this hearing just for you so that you could have a chance to share
my
your
training
ideas.
wheels. Thank
That's
you.
right. Ours too. You know, I'd like to ask you both. You both talked about prevention and innovation, which I really appreciate. And Director Kern, you talked about the difficulty of finding providers, given what's happening in Medi-Cal. I'd like to ask you both if you have thoughts on what our public hospitals would do that are in trouble financially. And I'm thinking specifically of a hospital in the community where I live, Doctors Medical Center, which serves maybe, I would say 90% of the people served are Medi-Cal, Medicare, or no insurance whatsoever. And it's a hospital that has operated for many years with an operational deficit. However, it is the only emergency room for more than 5 cities, and it is the only hospital, it serves about 60% of those in the community who have hospital needs. It has some specialized programs for heart disease and illness. You know, to me, it magnifies the statements that you all are making about how hard it is to find a provider. What do you do when your hospital goes away? And the county can't take it over? What are your thoughts about our public hospitals that, if they close, we won't be doing any prevention, right? We'll be doing stopgap measures that have to be costly and expensive. What thoughts do you have that you're willing to share about these, our public entities, or even private hospitals that are serving largely public folks?
Where I live, there's a district hospital that closed in Sebastopol, Palm Drive, a similar kind of issue. Communities more affluent, but they're still wringing their hands over the fact that the industry is changing. Times are changing. We're in a period of health reform, and we're having to re-engineer our health system. Things have also changed with regard to society. People have a lot more information at their fingertips about how to stay well or how to keep well or how to treat your own illness using the internet, using better information more readily available. We're becoming much more efficient in the way healthcare is done, especially if we have electronic medical records and telehealth and the ways of communicating so that you don't need to see a doctor face to face. Kaiser Permanente says it's seeing 70% of its patients by electronic means by the year 2015, so that's now. We're really, really advancing the way healthcare is done, and we don't need an emergency room on every street corner. At one time, we needed like we once needed fire in, houses on every block. We no longer need that in our society. So how do communities accommodate this great transition? There's some pain, there's some adjustment, but there's also some realities that we cannot afford to spend our way to health the way the American system is organized. You can't support infrastructures and facilities that are not up to the standard and up to the type of medicine that's being practiced today. That's why I'm talking about prevention, putting it in the hands of people to stay as healthy as they can in the first place, to become much more self-sufficient than they presently are, to demand less of the healthcare system, but stay a whole lot healthier in the long run.
Thank you. I have been aware of the situation with doctors, and I know Contra Costa Health Plan had done a lot of work in a lot of stakeholder community areas trying to think, because if you are having a heart attack, to have to go to Alta Bates or something like that is a real problem. I think this waiver that we are in the midst of developing, and we're hoping to have an application, a concept application for release to both the legislature as well as external stakeholders in the next probably few weeks for submission before we submit to the federal government. We're looking at how do we work with our hospitals to get off of a, payment based on having someone in the bed and having it be a cost-based reimbursement to more of a global budgeting strategy, which is, we want hospitals to be doing things that help encourage healthier behaviors, that increase the number of outpatient visits as opposed to relying on inpatient revenue. I think there's a lot of innovative mechanisms that were in place in the last waiver in terms of, we called it the Delivery System Reform Incentive Pool, the DSRIP, and those were for the public hospitals to undertake a series of activities to help make them more prepared for what is the coming way that the world is working on health coverage, which is it's a risk-based model. We are paying in a capitated environment in which you are taking a payment for a broader population, and you're expected to manage their behaviors and their health in a way that reduces inpatient and tertiary care and increases their opportunities for fewer medical interventions. And so I would be more than happy to go and look and see if there's something that doctors is specifically kind of in line for, because they're a district hospital and have a specific financing element that may be helpful.
Thank you. Mr. Bonta?
Thank you for your presentations. I also happen to, besides having the honor of serving on this committee, I also serve on the Health Committee, and this year as the chair. So one of the biggest issues we're going to be addressing this year is wrestling with the Medi-Cal reimbursement rate and trying to see if we can make progress this year. And I understand that the proposed budget didn't have specific increases to the provider rate. And so my question is more around what needs to happen first before we can make some progress in that area in the department's view. Are there some prerequisites or some areas where we need to overcome some hurdles and some obstacles before we can make progress in that area? Or is it just a pure budgetary mathematical issue?
Let me see if I can handle this. So there's And I think this is just an important way to start the conversation on the provider rates. Is we have two systems, right, in Medi-Cal. We have a managed care environment and we have the fee-for-service environment. The rate structure and the reimbursement mechanisms in Medi-Cal managed care, for which 75% of our population is now served, those rates are not in any way tied to the fee-for-service rate structure. So plans are paid using actuarially based rates that are signed off on by our state actuaries or our contracting actuaries, and then they're approved by federal actuaries. So, there is a safety mechanism by which we submit these rate packages, and they agree that amount of funding supports the overall risk of the population and the service area and the costs and things. So in managed care, it is a different environment in that plans have flexibility to pay providers what they need to pay in order to guarantee the access and meet the requirements that we have on them. So it's what physicians make in a managed care plan or through a managed care plan is not tied to fee-for-service. I think that the fee-for-service rates, there are numerous kinds of providers and numerous levels of payments attached. And I think that to the extent that the legislature is interested in starting a discussion with the administration about ways to increase that, it probably would be important to just understand what it is that you're trying to incentivize or what you're trying to fill in terms of an access point. If there's a critical access in fee-for-service that you don't feel is being met at the time, it would, we would obviously be providing technical assistance to both you and the administration about what does our data show and, what's the utilization in the claim system and things like that. And then that can help inform policymakers during a budget negotiation as to whether there is a way to do that. I think that any increase in Medi-Cal, given its size, there's probably approximately 3 million individuals in fee-for-service, even being in a managed care environment. Any increase is, by way of magnitude. So what seems very small, in a budget discussion, which is, if we increase rates by, X percentage, it'll be great. But it builds onto the base on an ongoing basis, which is why it certainly adds up quite quickly. So we would, be providing a lot of data and analysis to both the governor's office and to the legislature, if that's something that you guys enter into a negotiation. But that's, in some cases, why we did not propose it in the governor's budget, is the need to kind of continue to monitor some of the fiscal measures of Medi-Cal overall and the fact that so much of our population's in managed care today.
Thank you. Two more questions. One, if on Medi-Cal fee-for-service, if the reimbursement rate gets increased, I know there's no formal tie to managed care. Is there an informal connection? Would the financial models change if the fee-for-service reimbursement rate went up? Or are you saying it's totally on a separate track, has nothing to do, they have nothing to do with one another?
Correct, because managed care, so if you increase, for example, ambulance rates or non-emergency medical transportation and fee-for-service, the plans are required to provide non-emergency medical transportation. And so the only maybe indirect effect it would have is if the providers in the fee-for-service environment got a significant enough rate increase that they would maybe turn to the managed care companies and say, I'm not going to do business with you unless you give me a rate increase, which then would have the, then it would be a cost pressure in managed care if the rate increase was significant enough. But it just kind of depends on what you're increasing and to what level.
Does history tell us that that's true, though? Or the jury's out?
I don't know. I'd have to check. I don't know. That's a good question.
Okay. And then the second question is, if you kind of stepped back, and I appreciated it, and said, what problem are you trying to solve with increasing the Medi-Cal reimbursement rates? Let's say the issue is access, and that's the problem we're trying to solve. In your view, what are the most realistic steps we can take this year to make a significant difference in increasing access for those who need it most?
I think this is the fundamental problem with a fee-for-service system, in that there's no great way to actually analyze problems except in the rawest of forms, right? Fee-for-service means that there is a claim made by a provider and that there's a payment that goes out. And that's basically all it tells us, is that a doctor saw someone, and we hope that they saw someone, right? Because you also have inherent program integrity issues too. So you hope that someone saw a patient and that they submitted a bill to us and then we paid the bill. It doesn't necessarily tell you anything more. It doesn't say whether or not that physician had 40 people that wanted appointments, but he only chose one, or he only chose two, and so you're not quite sure. I know that we are trying to analyze access and trying to analyze the system to make sure that we don't have problems, but that is the reason why I think we've shifted to a more organized delivery system, because we rely very heavily on data from the plans. We rely very heavily on the laws that govern timely access. All of our plans, meet Knox-Keene standards. And so we have a pretty good idea of physicians and whether their panels are open, whether they're accepting patients. We have encounter data. We have quality measures. So we have a general sense of how the system is operating. Whereas, for your question, in fee-for-service, it is really hard to know whether there is access or whether there's adequate access or whether there's abundance of access. And it's not in any fault of the system, other than it's just not that sophisticated for data analytics. That help?